Dear colleagues, welcome to our fifth lecture in our clinical trials masterclass. Today is the first lecture in the EP module, and I'm very happy that my co-host, Baldi Kovac, who is resident in Zurich with a research focus in EP, is a co-host and helped me to organize this. Thank you, Baldi. Would you introduce our excellent guest today?
Sure, it would be my pleasure. Thank you, Javid, for the invitation and for organizing this great session. So it is my pleasure to introduce Professor Paulus Kirchhof, who is a professor in cardiovascular medicine and director of the Department of Cardiology at the University Heart and Vascular Center UKA Hamburg, Germany, and also holds a part-time position as professor of cardiovascular medicine in the Institute of Cardiovascular Sciences at the University of Birmingham. Professor Kirchhof is a trained cardiologist and electrophysiologist and researches in the translational mechanisms and management of cardiovascular diseases with a special interest in atrial fibrillation, cardiomyopathies, and heart failure. He has received several research prizes, has participated in several large-scale randomized controlled trials, most recently the East AF-NET4 trial, which was published last year in the New England Journal of Medicine. He sits on the board of the European Society of Cardiology, of the European Heart Rhythm Association, of the Atrial Fibrillation Network, the AF-NET. And I actually have him on the record saying that evidence-based treatments require randomized controlled trials, number one, and number two, understanding of treatment mechanisms and where the impact disease processes. And with that, I am very much looking forward to his talk in the subject of designing trials in arrhythmia treatment. Professor Kirchhof, thank you very much for joining us.
Well, thank you very much for those kind words. I'm flattered, and I'm really pleased to be with you. And I'm just trying to get the screen sharing to work. Can you see my slide?
Absolutely.
Perfect. It's wonderful to be with you. And one of the reasons why I like talks like these, there are two reasons. One, it makes you feel old. And at a certain age, that's a nice thing. At another age, it's not. And secondly, you are the future of cardiovascular medicine. I think David Cameron once said, I was the future once. And I hope that's not entirely true for me yet, but it will be true at some point. And then it's going to be your turn. So I've changed the title of my trial a little bit, and I'll talk about clinical trials in patients with atrial fibrillation. These are my disclosures, and I have a disclaimer. My disclaimer is I'll only talk about finished and published trials, and I will only talk about trials that I helped design myself, because I understood that this is sort of your interest with this lecture. So, to start off with, I actually spent some time thinking about what are the ingredients of a good clinical trial. And that's probably not only true for EP or arrhythmia. And I came up with 6 things. One is a clinically relevant question. And it's often helpful to be a clinician to come up with those questions, but it's not at all necessary. You do need a meaningful outcome parameter. And that's worthwhile to start thinking about at the start. When you design a trial, think about an outcome that matters to you, to patients, to your colleagues, to health economists, to a group of people who matter. I do think that it's very helpful to get a view from the outside. And that's what you get when you bounce your idea with colleagues. That's what you get when you talk about trial design with your methodologist, with your trial statistician, with the people who help you run a trial, and take that outside view seriously, because it'll help you creating a meaningful trial. And then you need power. I mean that in the statistical sense. Make sure that you don't run underpowered trials. And one of the biggest mistakes that EP has made historically is that we had so many underpowered trials. But also power in the sense of that you have to put a lot of your own energy and also financial power into running a trial. You will need time, and it will require a lot more of your own time than you think, and therefore you also need dedication. When you put these things together, you can have great fun designing and running clinical trials in EP. So this is how it started for me. I was a young resident at the University Hospital Münster, and we were convinced that when you do electrical cardioversion, that putting the electrodes at the front and at the back in an anterior-posterior position is better than what most people do, putting them anterior laterally. If I get this right, yeah. Good. Why is that the case? Well, this is a picture that I looked at a lot on the left at that time. These are two multipolar catheters in the coronary sinus and in the right atrium. Those of you who do invasive EP will recognize them. And you can clearly see that the coronary sinus catheter that goes around the mitral annulus on the posterior side of the left atrial wall sits posteriorly in the thorax. And you can even better see this on this CT scan. At that time, cardiac CT scans weren't that common, but you can see that the left atrium sits at the back of the heart, in the back of the thorax. And you can imagine that a shock field from there to there works better than a shock field from there to there. But there were no data. So we designed a trial. Randomized patients, actually not in an individual randomization, but in a block design where we just changed the methodology from 1 month to the other, to cardioversion in an anterior-posterior or an anterolateral electrode position. We used different shock strength. This was done with monophasic shocks. I'll come to that in a minute. And then we checked how many of the cardioversions were acutely successful. Now, this is the primary outcome. Successful cardioversion. Defined, meaningful outcome, and easy to define as sinus rhythm for at least a few beats after the end of the electrical shock. And the anterior-posterior shock electrodes were more successful than the anterior-lateral ones. And indeed, we had a crossover design. So at the end, the patients who had unsuccessful cardioversion after the last highest energy shock received one shock with the opposite electrode position with the highest energy. And 8 out of the 12 patients who did not cardiovert with anterolateral position cardioverted with the anterior-posterior. And the electrode reversal did not help anything in the 2 patients who failed cardioversion with anterior-posterior. You could also see that this success rate was higher for each energy chosen. And this is a beautiful picture because it's my first attempt at a consort chart, what is now called a consort diagram. And when you design trials, and especially when you report trials, please use these because they are by far the most clear and informative way of reporting outcomes. We then did a second study, because at the same time when we ran the trial, people became aware that biphasic cardioversion shocks were actually more effective than monophasic. And therefore, we tried to do a 2x2 factorial design using different electrode positions and monophasic and biphasic shocks. And I'm not going to go through the details, but we basically found that both the type of electrode, paddle electrodes made out of metal, are better than the patch electrodes that you glue onto the skin, and the cardioversion energy, biphasic versus monophasic shocks, are both important. So that in summary, and that's the summary, if you wish, of my first decade of doing clinical trials, if you do a cardioversion, use biphasic shocks. Other people showed that before us. Use a truly anterior-posterior electrode position, and if you can, use pedal electrodes. Now, the latter is very difficult to do in clinical practice because they are no longer made. So unless you have an old pair somewhere, you will have to use the glue on one-time use electrodes. You can improve the outcome by putting pressure on them. This is a paper that was published while I was still a medical student, but that was discussed and read a lot when I was an EP trainee. A group in Maastricht, led by Maurits Alessi, implanted pacemakers into healthy goats, exposed them to burst pacing, and after 2 weeks of burst pacing, the goats developed sustained atrial fibrillation. Atrial fibrillation begets atrial fibrillation. The same group also showed that the changes, particularly the electrical changes that lead to this electrical remodeling, are reversible after 4 weeks of sinus rhythm. Now, that was the starting point for the so-called FLECAS-L or Flecainide short-long trial. And this is the design of that trial. Again, it used patients who underwent cardioversion, and it randomized them to 3 groups. One was a control group that did not receive antiarrhythmic drug therapy. The third group, the bottom group, was a group that received antiarrhythmic drug therapy for the entire duration of the follow-up, 6 months, which was the standard of care at the time. And the third group received antiarrhythmic drugs for 4 weeks only. And the hypothesis was that the short-term antiarrhythmic drug therapy targeting electrical remodeling would be non-inferior to the long-term therapy. Based on these observations in healthy goats, that should be the case. I learned a lot designing that trial, both on trial design from an excellent statistician here in Hamburg, Karl Wegscheider and his team, but also on running a trial outside of your own hospital, something that's called a multi-center trial. I was also lucky because at the time that we came up with this idea, my then boss, Günther Breithardt, was able to obtain quite a bit of public funding to create the atrial fibrillation competence network, government-funded research network into atrial fibrillation. And the centers in this AFNet were then the participating centers in the FLECSL trial. And you can see a picture here of all the sites in Germany. And the size of the circle is proportionate to the number of patients that were enrolled. And you can see a big blob up here in Münster. That's where we were at the time. But of course, you can also see quite a few other centers that contributed very well. This is the primary outcome. And you can see it's a bit more complicated. It's a survival curve. So it reports the proportion of patients that are without a recurrence of atrial fibrillation in the 3 arms. And you can, on one hand, clearly see that antiarrhythmic drug therapy in red and blue leads to fewer recurrences than no antiarrhythmic drug therapy. But you can also see that the short-term treatment in red has a worse outcome than the long-term treatment. Or, to put it precisely, the short-term treatment is not non-inferior to the long-term treatment. If you want to quantify it, the short-term antiarrhythmic drug therapy conveys approximately 80% of the antiarrhythmic drug effect of long-term therapy in these 635 patients undergoing cardioversion. This is a landmark analysis. You'll probably have heard about that because heart failure people do it a lot. And this shows the recurrences after the first 30 days. So when the treatment between the red and the blue group differed. And you can clearly see that there were quite a few recurrences in the short-term treatment group. Now, I then moved a bit, and this was the time when the NOACs or the DOACs, however you want to call them, the direct inhibitors of factor 10A and factor 2A entered clinical atrial fibrillation care. And one of the things that was unclear was whether they can be used in patients undergoing catheter ablation. There was a lot of concern about reversal of these agents. There were even questions whether you should do things like a transeptal puncture on continued anticoagulation. And we found a partner, an industry partner, BMS Pfizer, and support from the German Center for Cardiovascular Research within the AFNet to run a trial that randomized patients undergoing AF ablation to either vitamin K antagonist therapy or to factor 10A therapy with apixaban. All patients underwent the first AF ablation. I'll show you the design now. All patients had at least a CHARTS-2 score of 2. And then the patients were enrolled in 50 centers in Europe and in the US. And patients were randomized to apixaban or vitamin K antagonist therapy. All of these therapies as continued anticoagulation. Excitingly, we did a brain MRI sub-study in about half of the patients. And that brain MRI was done a day or a few hours to 2 days after the AF ablation. And then we checked for a composite outcome of what we call the net clinical benefit of stroke and bleeding. AXAFA AFNet5 was the second biggest trial ever to be done in this setting and the trial that randomized most ablation patients. But it was underpowered. I told you about the importance of power. It was powered for a non-inferiority margin of plus minus 30%. The MRI study, however, and we are still working on the results, revealed quite a few interesting things. This is a picture that we had when we designed the trial, where you can see this is a summative picture showing the location of asymptomatic acute brain lesions that occur after AF ablation in many patients. Each patient is one color. And you can see that they are not so rare. And I was fortunate to be able to work with really smart neuroradiologists and neurologists, particularly Georg Häusler, who's now in Würzburg. And they helped us to design this sub-study of the AXA AFNet5 trial. So this is the flowchart. This is the consort flowchart of AXA AFNet5. And you can clearly see that we randomized 674 patients, of which 328 and 327 received study drug, and then 318 and 315 underwent AF ablation. The primary outcome was a composite of stroke, serious bleeding, and death. And I'm not going through the baseline characteristics, but this is the primary outcome. And it tells you a very clear story. And the main story that it tells you that AF ablation is a very safe procedure when done on continued anticoagulation. The other story that it tells you, and that was the question that we were trying to ask, is there is no difference between vitamin K antagonists and NOACs, and they can both be used in an uninterrupted fashion in that setting. Now, we clearly managed to hit the non-inferiority margin that we designed the trial for, and we actually found that the events were very similar, so that I'm quite confident to say that there is no difference between vitamin K antagonists and the NOAC. But in fact, if we had done the trial in 1,500 patients, we would probably have been able to publish it better and would have given a more robust information on the non-inferiority of apixaban versus vitamin K antagonists. These are the pictures that we got from the MRI sub-study, and I'm really grateful to all the centers who did these MRI sub-studies, and we are still learning from them. And because of the very intelligent MRI sequence, we could differentiate between acute and chronic lesions, and we could detect very small lesions because we used a slice thickness of 2.5 millimeters for the brain MRI. So what we found was that we actually had approximately 3/4 of patients without silent brain lesions and 1/4 of patients with silent brain lesions. And there was no difference between the groups. And for that sub-study, the trial is actually very well powered because you have many events. So this is potentially the more robust finding when you want to compare different anticoagulation regimes in AF ablation. More importantly than that, we did not find a difference between the cognitive function between the groups at 3 months follow-up. And interestingly, that's highlighted in red here, cognitive function actually improved slightly at 3-month follow-up compared to pre-ablation. Now, we didn't design the trial to assess whether AF ablation improves cognitive function. We included the cognitive function test as a safety measure to ensure that we would capture cognitive decline, which had been reported in other trials with AF ablation, not using continued anticoagulation. But it was reassuring to see that cognitive function actually improved in both groups without differences between groups in those patients, despite the detection of these silent acute brain lesions. We're still working on sub-analyses, as I've told you. Now, these were the trials that are published until 2018, and last year was probably one of the better years in terms of clinical trials for AF. This is a picture from a healthy goat that has not undergone pacing. I have it from Uli Schotten, one of my friends and colleagues in Maastricht. And you could easily see what a pretty, wonderful, aesthetic, complex structure the atria are when they are healthy. These are biopsies taken during thoracoscopic AF ablation. And even though it's not the entire atrium, it's only a biopsy, you can clearly see that this integrity and the structural organization of the atria are lost in atrial fibrillation. So it's further illustration of the concept that atrial fibrillation damages the atria. Now, this was known 10 years ago. And even the structural effects of atrial fibrillation and their potential reversibility had been shown in experimental studies. And this was discussed, and this is probably another point for those of you who want to design clinical trials. Try to make friends. One, because it's nicer to live with friends and to discuss with friends, but also because they may help you. This is one of the larger European conferences that we organized with the AFNet together with the European Heart Rhythm Association. This was actually the second AFNet era consensus conference. And during that conference, we discussed the concept of early rhythm control therapy. Now, this was 7 years after Affirm and RAISE were published, so everyone had accepted that rhythm control is only there for symptom improvement, but we didn't. We thought there may be something more to it. And it was quite helpful to get the reassurance from colleagues who were a lot more senior than I was at the time and who came from different ways of life, had looked at atrial fibrillation from different perspectives, that they also thought that this concept of early rhythm control could actually be helpful. Now, this is from the last AF guidelines that were presented and published just before we published the EAST trial. And I think they're very good, but I do think that recommendation has to change. And it states that rhythm control therapy is recommended for symptom and quality of life improvement in symptomatic patients with atrial fibrillation. And all the literature that this recommendation is based on is given at the bottom. So I'm now going to talk about the early treatment of atrial fibrillation for stroke prevention, or EAST AFNet 4 trial. The fourth trial that the AFNet did as a controlled clinical trial, and one that took 10 years to conduct and finalize. And it addressed the very simple question, does early rhythm control therapy improve outcomes compared to usual care in patients with early, recently diagnosed atrial fibrillation at risk of stroke? EAST AFNet 4 was a unique cooperation between AFNet, who was the legal sponsor of the trial, and the European Heart Rhythm Association, who together designed the trial and helped it through to the end. And another, if you wish, stroke of good luck was that we finished follow-up on the 6th of March, 2020. And you may recall that this was the time when the first wave of the COVID pandemic hit Europe. So it's probably one of the last trials that was not affected by COVID in terms of outcomes. So what did EAST do? It took patients at risk for cardiovascular events, CHA2DS2-VASc score of 2. Those are the ones that have events, and therefore that's why we chose that group. And with recently diagnosed atrial fibrillation, early atrial fibrillation defined as less than 1 year duration at the time of randomization, so that we would be able to test early rhythm control therapy. And they were randomized to usual care, in black here, and usual care was everything that the guidelines recommend: anticoagulation, rate control, treatment of underlying conditions, and rhythm control in patients who remain symptomatic on rate control. Early rhythm control was the intervention group in blue here, and that consisted of the same background treatment plus rhythm control in everyone at the time of randomization. All patients received therapy of concomitant cardiovascular diseases, and all patients were followed for a median of 5.1 years. I've shown you the map of Germany for the FLECSL trial, and here AFNet enabled me to run the trial in Europe, which was truly exciting and one of the best things that I did in my life, because I met so many amazing people across all these European countries. EAST was done in 135 centers in 11 countries. I actually took this slide from a report that I had to give to a group of people in 2014. And some of the people who helped me run the trial are listed here. So the patients were a typical cohort of patients with recently diagnosed atrial fibrillation. All comers with recently diagnosed atrial fibrillation. More than half of the patients were actually enrolled in sites that do not perform AF ablations themselves, including large cardiology practices that see a lot of general cardiology patients. Background therapy was not different between randomized groups. Now, that is a key question on every randomized trial. Are there other differences than the randomized treatment that could explain the treatment effects? There was no difference in anticoagulation, shown here between groups, and also no difference in blood pressure, which is a good surrogate for antihypertensive and heart failure therapy. Early rhythm control was delivered using antiarrhythmic drugs in most patients. At 2 years, every 4th patient randomized to early rhythm control had undergone AF ablation. Usual care did not use rhythm control in the patients at baseline, only in 4%. And at 2 years, approximately every 7th patient had received rhythm control therapy, as you would expect from treating symptoms, because that's approximately every 7th patient. You've seen the primary outcome, I guess. I'm still excited by that slide. You can clearly see 21% reduction in a composite outcome of cardiovascular death, stroke, and hospitalization for heart failure or acute coronary syndrome in the patients randomized to early rhythm control compared to usual care. Usual care, by the way, exactly hit the event rate that we expected, 5% per year of first primary outcomes. And that illustrates the adequate treatment of underlying conditions, adequate anticoagulation, adequate rate control. Every component of this composite primary outcome, cardiovascular death, stroke, worsening of heart failure leading to hospitalization, or acute coronary syndrome leading to hospitalization, was numerically lower in patients randomized to early rhythm control. This Sankey plot, they are lovely plots to show changes over time, shows you how patients were treated over time. On the left, early rhythm control, on the right, usual care. And you can see that most patients actually stayed on antiarrhythmic drugs. There are always things that you can learn when you analyze a trial that you didn't expect. And this is one of the things that we didn't expect. We expected more patients to need AF ablation in early rhythm control, and we expected more patients to go back to atrial fibrillation in usual care. 60% of the patients randomized to usual care were in sinus rhythm at 2 years follow-up. But you can also see that AF ablation is an important component of early rhythm control therapy. And as I said, every 4th patient in early rhythm control had undergone AF ablation at 2 years. Now, the main problem of rhythm control in the earlier trial was its safety. And that's another simple lesson. When you talk about intervention, you have to consider efficacy and safety. And one of the problems of antiarrhythmic drugs at the time of affirmant raise was probably that antiarrhythmic drugs were used in a way that was not always entirely safe. And also that there was no escalation step to AF ablation 20 years ago. Safety of early rhythm control was really good. The primary safety outcome was a composite of stroke, death, and serious adverse events of rhythm control therapy. It occurred in 223 out of 1,395 patients randomized to early rhythm control, and in 231 in early rhythm control and 223 in usual care. No difference. Numerically, there were fewer deaths in patients randomized to early rhythm control. 9.9 versus 11.8%. Not statistically significant, but clearly not a safety signal. There were, of course, adverse events related to rhythm control therapy, but they were few. Only 10 out of the 1,400 patients had serious adverse events of catheter ablation, and only approximately 30 of the 1,400 patients had serious adverse events related to antiarrhythmic drug therapy. Now, because the trial attracted quite a bit of attention, it was presented last year at the ESC and published simultaneously in the New England Journal of Medicine, we thought it would be good to do some sub-analyses. And one of the subgroups that probably has attracted most attention in terms of rhythm control therapy are patients with heart failure. So we looked at the 800 patients with heart failure randomized in the EAST-AF-NET4 trial. Most of them, by the way, with heart failure with preserved ejection fraction. And we checked whether early rhythm control, the randomized intervention, had an effect on the primary outcome. And it did. Not unsurprisingly, but still remarkably. Early rhythm control reduced the primary outcome of cardiovascular death, stroke, or hospitalization for worsening heart failure and ACS in patients with heart failure, despite the concerns that we all have in using antiarrhythmic drugs in patients with heart failure. And again, the majority of patients were treated with antiarrhythmic drugs. We also analyzed an exploratory outcome that combines total mortality with heart failure hospitalization, an outcome that is used a lot in heart failure trials. And that was also reduced by early rhythm control compared to usual care. Interestingly, we saw this clinical effect of early rhythm control without changes in left ventricular function. Both early rhythm control and usual care were very good at improving left ventricular function in patients who entered the trial with a reduced left ventricular function. And neither of them had an effect on patients who already had a good left ventricular function when they entered EASD-AFNIT4. Now, when you take the results of EASD-AFNIT4 and implement them, you notice that the biggest change in practice will be in asymptomatic patients. So we did another sub-analysis where we checked whether the early rhythm control therapy intervention was as effective in asymptomatic patients as it was in symptomatic patients. Fortunately, we captured the symptom status using the error score at baseline. So we could classify patients into asymptomatic, error 1 on the left here, or mildly or moderately symptomatic, error 2, or severely symptomatic, error 3 and 4. Now, obviously, you lose power when you create these subgroups because the trials, you basically take out a large number of patients and therefore a large number of events. But we could, one, show that there was no interaction between symptom status and the outcome, and two, that the patients randomized to early rhythm control had less outcomes in each of the symptom groups, whether they are asymptomatic, showing on the left here, or severely symptomatic, shown on the right. So that in summary, when I summarize EASD, I do think it is a practice-changing trial because we had a good question, we had the power, and we were lucky to come at a good time. Early rhythm control therapy can actually reduce cardiovascular events by 20% on top of optimal guideline-recommended therapy in patients with recently diagnosed atrial fibrillation. And it achieves the same clinical benefits in patients with heart failure across the spectrum from HFrEF to HFpEF, and in patients with and without AF-related symptoms. And therefore, in patients with recently diagnosed atrial fibrillation, think anticoagulation and rhythm control. So when I think back over the last 20 years, where I was involved in clinical trials, and I've shown you a few examples now, I do think that this list actually carries relatively far. Try to find a clinically relevant question and a meaningful outcome parameter. Get a view from the outside, and then, point 4 is important, make sure that you have the power to run an adequately powered trial. There's no point in spending a lot of energy and resources, and in the end, patients consent into a trial that is underpowered, and accept that it will take a lot of time and dedication. Thank you very much. I hope you enjoyed this, and now I look forward to your questions.
Dear Professor Kirchhof, thank you very much for this excellent presentation. I have to say I very much enjoyed the arc you showed us with starting with a small randomized controlled trial and steadily increasing and culminating in this incredible trial with the EASD-AFNIT4. First of all, Javid, I wanted to see if anybody has any questions so far in the chat. I apologize, I forgot to warn beforehand to post questions at any time during the talk.
So there are 2 questions, but go ahead and I will follow. All
right. So my first question is, I appreciated what you mentioned regarding the power when designing especially randomized controlled trials. And what struck me with your last trial with EASD-AFNIT was that you actually increased in the beginning the sample size of of the trial because the event rate wasn't as high as expected, as always almost happens with trials as far as I've seen. And then actually the trial was terminated early on the recommendation of the Data Safety and Monitoring Board. And I was wondering how that came to happen, and as an experienced trialist, how you react to a recommendation by the Data and Safety Monitoring Board regarding early terminations, because we have discussed it many times in our sessions at Oxford, and one of the things that we notice a lot of times, that there's a loss of information. Obviously, we do not want to harm patients, and we do not want to withhold good therapy if the trial is positive, but still it's a conundrum every trialist probably finds themselves.
Now, regarding your first question, one of the things that I've learned from the methodologists I had the pleasure to work with is that it is actually a good idea to plan a blind interim analysis with sample size adjustment. And there are a few simple reasons. One is you may be wrong about the event rate, and most people are too optimistic, or too pessimistic about event rates. They expect more events than actually happen. We actually hit the expected event rate in EAST-AFNet-4, but there are many other mechanisms, including if you don't enroll exactly at the rate that you expected to enroll, and that is almost always going to happen, unfortunately, then you will change the follow-up time of each patient, particularly when you have, as we did in EAST, when you accept that you will follow all patients until the end of the trial, rather than saying, I'll stop follow-up at a defined point in time. And therefore, it is very easy, and it doesn't cost any power if you say at a certain point, we said after, I forgot the exact numbers, but I think we wanted to do it either when 3/4 of the patients were enrolled or when half of the events had occurred. You look at the event rate without unblinding, and then you can say whether the event rate is in the range that you expected, or whether you actually need a few more patients or a bit more follow-up, and that's what we did. So that's the easy bit. The difficult bit is the Data Safety Monitoring Board. And I think the first simple advice that I would like to give is find the most experienced and most trustworthy people to put on Data Safety Monitoring Boards. It's one of the hardest things to see a trial evolve, knowing that what you see is unknown to anyone else, including the steering committee, and being rational enough about it to say, well, look, we have to carry on until we have a clear signal, but also rational enough to say, well, look, if we add a few more observation years, we will not get a better signal. So that's the first thing. The second thing is when you're called as a chief investigator or principal investigator, whatever you want to call that person, and you get the information, and you don't get more at the start, the Data Safety Monitoring Board recommends to stop the trial because of efficacy. You first start to smile, right? I mean, it means you found something, and it could actually be that your hypothesis was correct. So that was my first reaction. I still remember where I was when I got the phone call. But then, of course, you have to start due diligence. And even though you're probably less experienced than the people on your Data Safety Monitoring Board, you have to step one step back and ask all the difficult questions. And it's actually, they are difficult questions because the answers are painful. They are not difficult to ask. You have to put yourself into the position of someone who hears about the trial, and you have to imagine all the potential outcomes. And you have to ask yourself, well, what type of robustness do you need to accept that outcome? So in the example of EAST, how robust does the finding have to be so that you accept that early rhythm control is important? And you can't do it with the result in view because you haven't seen the results yet at that point in time. And then, of course, if your hypothesis was not true, if early therapy was unsafe, or if early therapy was ineffective, what type of robustness do you need? And it's actually quite easy to answer those questions because you've written them down in the protocol. And a good Data Safety Monitoring Board sits down at the start and writes down stopping rules. And that's what our Data Safety Monitoring Board did. And they basically follow those rules because That's because you do get emotional when things change, and you do tend to interpret things into curves when you see them start to diverge or not. So that I think in our case, it was we did the right thing. We wouldn't have gotten much more confirmation. Now, this is actually the third thing is that when you say we'll stop the trial now, of course, the observation doesn't stop. All patients are contacted once more, so you actually collect a few more events. So this is another reason that as a steering committee, you want to make sure that you have the robustness that you need, because you know there'll be a bit of noise coming in from all sides. The result will change. So I think we stopped at, I don't know the exact numbers, but around 525 first primary outcomes was when the third interim analysis was planned. And these, by the way, were planned interim analyses with alpha spending. But in the end, and you can read that up, I think we had 565 first primary outcome events in the main paper. So these 40 events were found between stopping the trial and closing the database. So interesting, but I do think we did the right thing in our instance. But I also agree that there has been a tendency, at least in the past, to stop trials a bit early.
I found this aspect especially interesting because just to mention the p-value, you reported 0.005, and regulatory agencies, for example, the FDA, they either need 2 randomized trials for the same treatment to accept it as an indication for a specific disease, or they also accept a p-value of 0.05 squared, which would be 0.025, which is just missed by the East AF-NET 4 trial. And I was wondering, would that impact in any way how a recommendation level put by, for example, the ESC in the next guidelines?
So the short answer is no. But I will, and I don't think that there is any meaningful difference between a p-value of 0.005, 0.004, or 0.001. That is not a valid comparison. But now actually brings me almost to to a different topic. Almost all of the trials that I've done are strategy trials, maybe with the exception of AXA for AF-NET5. So what we did in EAST is we tested a different timing of approved and tested treatments in their indication. And therefore, the safety was actually known at the time of starting the trial. Now, that's different from testing a new drug or a new device or a new intervention. And therefore, many of these rules, which aren't set in stone, no one is deciding only on the third decimal after the dot at a p-value. The FDA actually, or the EMA more than the FDA now, has a tendency to look at the totality of the evidence, even for new medications or interventions. But here, for a strategy trial, I would argue we have good data on the safety of antiarrhythmic drugs and catheter ablation. And actually, we are in the process of generating some of that data using observational and health record data sets. And the looking at the p-value will not help you. If you're interested whether you should base treatment decisions on the outcome of a trial, I would say read the design paper and look at the power. That's why I think power is important. And it is painful because it means that you need larger trials and therefore more centers, more patients, more time, more money, more everything. But that's how you generate meaningful results. And it doesn't matter whether a p-value is different.
Absolutely. Yeah. Javid, how is the situation regarding questions?
There's one question from Dr. Kader, for example, regarding, so we would go chronically back to the AXA AF-NET question. And her question is it common to choose net benefit as a primary outcome in anticoagulation trials, as it composites essentially, can go into different directions when it comes to stroke prevention or bleeding? And what do you think about that problem?
So for an anticoagulant, I think you need for a new anticoagulant, I think you need a primary outcome that has the efficacy component, so stroke, systemic embolism, maybe stroke, systemic embolism, and cardiovascular death. And you need a safety outcome, that is bleeding and total mortality, or bleeding and then total mortality added to it. When we started Axafa, again, it was testing an approved substance in an indication. I think one of the reasons I told you that Axafa was, in a way, not powered as highly as we wanted it to be powered. But I do think it is a meaningful trial. And the reason is that the concern with the NOACs at the time was that you would have an excess of bleeding because you can't antagonize the NOACs, you can't stop them, all these, you may recall these discussions from a few years ago. And therefore, I do think in this instance, and at the same time, there was a concern that if you change anticoagulants, if you interrupt, if you treat bleedings with prothrombotic substances, you will actually increase the number of strokes. When you look at the outcomes in Axafa, I think we had a total of 3 strokes or 2. So it is essentially a bleeding outcome that was measured there. And I do think that was what was the driving force for the decisions at the time concerning anticoagulation peri-ablation. So it was a reasonable and a good primary outcome there. We should have done the trial with double the patients, but then one has to accept that there were 2 other trials similarly sized that yielded almost exactly the same results. So I think that the totality of evidence that we now have is sufficient. But in this case, I think the net clinical benefit outcome was a good one. But for a new anticoagulant, or for extending the indication for an anticoagulant, we're, for example, doing the NOAA IFNet6 trial, which is ongoing. And there we have a clear split between an efficacy outcome, stroke and death, and cardiovascular death, because many strokes lead to death, and a safety outcome, which is major bleeding and total mortality.
So when I see correctly, in Axafa and in East, in both cases, you had a power of 80%. Mm-hmm. And when you say adequately powered, what is it adequately powered, or is it a trade-off of what we aim for and the feasibility? Yeah. Is it, how?
So I would really suggest that you try to do adequately powered trials. When we started East 10 years ago, a power of 0.8 was the industry standard, and all the large trials, even the registration trials at the time, were done at a power of 0.8. Many public funders now require a power of 0.9, greatly increasing the number of patients needed and the effort and the resource for each trial, but also, of course, ensuring that there is much more precision in the outcome. So if you can do a trial with a power of 0.9, please do. But I do think that if we were to redo something like East, we would probably again go for a power of 0.8. And that again comes back to the strategy trial nature of that particular study, where it is very unlikely that the treatment pattern would cause harm, because each of the components of the treatment has already been tested. But yes, there is a move towards a power of 0.9. And for example, the NIHR in the UK requires it. I do think the NIH is moving that way as well. There are pros and cons to it. Even doing a 3,000 patient trial isn't always easy. And doing a 5,000 patient trial is 40% more difficult.
So in East, you calculate, when we're thinking about sample sizes, we have to think about effect sizes too. And you calculated a 20% effect size difference between both groups. Please apologize when I'm too ignorant here, but when I think about the early rhythm control group, there's different treatment options within that group. So I would think about different effect sizes depending on the treatment you have. And how would you calculate then the effect size for the overall effect between the two groups?
Estimating effect sizes is one of the most difficult bits of a controlled clinical trial. Many funding agencies now require pilot or feasibility trials. We didn't do that in EAST. We didn't do it in NOAA or AXAFA, but it's one way to see whether the trial team actually has the ability to deliver a trial, to enroll the first patients, but also to see whether you can get an effect. The problem is that even with a pilot trial, you don't have sufficient information to estimate the treatment effect. So there you are really relying on best interpretation of the available evidence. That's where I find where a steering committee, a group of people who are willing to sort of put that knowledge together and bang their brains and ensure that you get a good estimate is really helpful. Most committees, because they have a reason to support the hypothesis, that's how you convene such a group. There are people who think, yeah, early rhythm control therapy is good, we have to try it, will overestimate effect size. So my simple advice is take your best guess and then reduce it by 25%. That's actually what we did. We debated a lot about should we power EAST for an effect size of 25% or for 20%. When it comes to the components, I'll get back to you next year because many people ask this. The law of the land or the estimate of the land is that AF ablation conveys a greater benefit than antiarrhythmic drugs. We have not done a trial, and the only trial that has ever tested this was Cabana, and it had a neutral outcome. Whether adequately powered or not, you can debate, but it had a neutral outcome. But we will do a complex modeling analysis. It's already taking over a year, and we've probably wasted several gigawatts of energy to run the modeling. But we will hopefully know it next year, or we will have some information from the EAST AFNet4 data sets, whether the different components made a difference on the outcome.
How were you thinking about while designing the trial? Was it, for example, what were your estimations, your sophisticated gut feeling? Was it antiarrhythmic drugs? The drugs would have a lower effect than 20%, the ablation more, and so you trade off and you say 20% is fine, or
so. Our expectation was that maintenance of sinus rhythm is the thing that matters. And we expected that many more patients would have recurrences on antiarrhythmic drugs and then move on to AF ablation. So our expectation was that AF progresses faster than it did. And one of the biggest surprises that we had was, as I said, the sinus rhythm rate at 2 years in the usual care group. 60% is quite high at 2 years. But that's the natural progression of early atrial fibrillation treated with rhythm control only when symptomatic. And quite a few patients in usual care never had a recurrence of atrial fibrillation. When we designed the trial, we expected that the majority of patients in usual care would be in persistent or chronic atrial fibrillation during the follow-up, and they weren't. So that's where we got it wrong. But we didn't have to split the effect of antiarrhythmic drugs and AF ablation. When we designed the trial was in 2010. AF ablation had been around for a bit over a decade, was an established method, but really only established as a second-line treatment. Mantra Puff was published in 2012. So we thought of AF ablation as the rescue treatment when antiarrhythmic drugs fail. And therefore, we considered the combined effect. Didn't have to compare the components.
I had a question regarding the composite endpoint. So you mentioned it's very important to choose a clinically meaningful endpoint, and I really appreciated actually all 4 components of the composite endpoint had a similar reduction in the numbers, which is actually what one would wish for. I was wondering, when selecting these components, what was the rationale behind choosing ACS as one of the components, since we're trying to, we are selecting endpoints which are affected by our treatments, and I was wondering what the idea was behind that.
Yeah, so I think you actually outlined the thinking. We try to identify a composite of events that are meaningful for patients, also events that are clearly defined. That is important for an outcome, particularly in an open trial, so that you cannot debate, is this really a heart failure hospitalization or not? And events that are linked to the intervention. We were thinking at the time that in atrial fibrillation, that some patients who present with acute coronary syndrome have that presentation because of atrial fibrillation. And I think nowadays we would call them type 2 myocardial infarctions. We didn't have that term 10 years ago, but we had the clinical picture of these patients. And when you look for the components, ACS was the one that contributed least to our outcome. So it was relatively rare.
Thank you. Javid, any other questions from the audience? Otherwise, I still have plenty.
Yeah, there are two more questions from the audience, and I have two quick ones. I know we appreciate your time.
No, it's fine. It's good. All good.
There is one question from Dr. Cutter who says, also in AXAFA, how do you pick trial participants for the imaging substudy? Is it those who were enrolled from a center with an MRI, or is it all of them, or are they randomized? How do you pick them?
Brilliant question, and it's actually a very good question, because there is a potential bias in every substudy. And what we did in AXAFA is we asked each center at the start, do you want to be an MRI center or not? And 25 out of the 49 centers were MRI centers, and they enrolled all patients in the MRI substudy. Now, there is a caveat, because, of course, when patients decline the MRI, you cannot force them to have one. And in some centers, we had a remarkable incidence of claustrophobia. So yes, we didn't get all of them, but we got more than half of the patients who had an MRI, and they were in MRI centers. So I think in terms of the bias, we tried everything to minimize that. You can, in a way, look at the MRI substudy as a 25-center MRI ablation study.
Yeah. When you look at the East early rhythm control group, how do you maintain blinding when you have an interventional treatment and you have a drug treatment?
Yeah.
How did you manage the blinding component in the trial?
So East was designed as a probe trial. I didn't say that in the interest of time. So it was a prospective, randomized, open, blinded outcome assessment trial. So both the patients and the investigators knew the randomization arm and delivered the therapy accordingly. And I don't think it's easy or even feasible to do an ablation trial as a sham-controlled double-blind trial. Well, even a single-blind trial would be difficult. What we did was we did not tell the adjudication committee the randomization group. And because all interventions were possible in both arms, I mean, they could try to infer that this ablation-induced bleeding was in a patient randomized to early rhythm control, but they didn't know, because 1 in 7 patients, as we now know, randomized to usual care, also underwent rhythm control. And so we had blinded outcome assessment. We didn't tell the adjudication committee the randomization group. And that way we maintained blinding.
I have two quick questions which are linked. Then, Baldi, you can ask your questions if you, then we can wrap it up. So one is, could you elaborate, because the term of strategy trial? You said that that you perform strategy trials, and that obviously is different from other trials. That would be interesting to hear. And the second is, why are there no outcome trials required to introduce invasive procedures in rhythm control when it is needed and required for pharmacotherapy? Is it a financial incentive this is what a lot of the drug guys say, but what is your explanation for that?
So the first one, what is a strategy trial? It is what it is. It is a trial that compares two treatment strategies, and I think there are other fields. So when we started FLEC-SL, which in a way is also a strategy trial, right, where you withdraw treatment, I was working in Münster, and Münster at that point was one of the big centers for therapy optimization trials in oncology and in pediatric oncology. And I think that's actually an area of medicine where we can learn a lot. More than 3/4 of all patients with acute leukemia are treated as part of controlled clinical trials. And go back to your hospital, you find out how many patients you treat who are not part of clinical trials. So a strategy trial, in my understanding, does exactly that. It takes current best care and compares it with something that you think will be better than current best care, and randomizes patients. And that's, again, you've quoted me, Boldizar, at the start. I don't think there is any other way than answering a question whether a treatment that I think is better is actually better than doing a randomized clinical trial. Now, these are trials, in my view, that should be done with a low threshold for entering them, and should be possible to do without a lot of the pharmacovigilance and the regulatory requirements and the follow-up intensity that we require for introduction of new interventions. Now, when it comes to your second question, I think part of it is a culture. The culture of introducing a new drug is different to the culture of introducing a new device. A part of it is also that the outcome of an intervention depends a lot on the team that does the intervention. And therefore, it's a lot more difficult to compare device A to device B. And even more so when you develop a device for a new intervention. So for example, vitamin K antagonists were introduced into clinical medicine based on a human experiments N=1. I think it was a veteran of the Korean War who tried to kill himself with a bag of rat poison, survived, and that was the introduction of vitamin K antagonists into clinical medicine. They didn't have a comparator then. It was also a different time. And when you introduce the first left atrial appendage occluder, what's your comparator? And you can read the literature on LAA occluder trials to find out, and you can actually learn a lot by it. I'm not going to comment on the details, but you can learn a lot by it, and a lot has to do with power, but some of it has to do with picking the right comparator. And the same is true when you now introduce a new ablation device. A lot of the complications that, I don't know whether you're an ablationist, but we are in a big ablation center. We evaluate quite a few new devices. And complications happen, but do they happen because of the device? Do they happen because of us? Do they happen because of other things that are related to other aspects of the intervention? So it is also a different area. But I do also think, at least in Europe, and this is a course mainly for Europeans, right? So the grace period for the medical device regulation of the European Union, well, it doesn't apply to our UK colleagues anymore, but for the European Union has expired. So that we will see, I think, a lot more rigor in the evaluation of new devices in the years to come.
If you don't mind, I have two questions.
Okay.
They should. One of them is short, and the other one is maybe a little bit more complicated. But I was hoping to hear your opinion. Number one was, you mentioned several trials which tested anticoagulation in subclinical atrial fibrillation, which is a massively growing field, especially with the new wearable devices. And we didn't have many positive trials. Recently, we had the Loop trial and the Stop Stroke trial, of which I believe Loop trial was negative, but Stop Stroke did show some benefit. And I was wondering, would you think, in regard with regard to EAST-AF-NET, that these two trials would have been more positive if all patients also have had a rhythm control strategy? Additionally, since EAST-AF opens a very wide population who qualify for treatment. And my second question was, we had the honor of hosting Professor Fayez Zanad a couple of weeks ago, and I saw another talk by him where he mentioned that we are getting really good in clinical trials, but what we absolutely need is implementation. So this also goes to my previous question: how would you advance implementation based on ECFnet?
So to your first question, we actually we were lucky. In October, we had the 8th AFNet Era Consensus Conference, and we had the lead investigators from Loop and StrokeStop here. So that was really interesting. I think the short answer to your question is no. But just to clarify, StrokeStop was a study that used conventional ECG screening to identify patients with atrial fibrillation and then start anticoagulation. Loop was a study that used implanted devices, so something akin to a device that detects atrial high rate episodes. I preferred that term because subclinical atrial fibrillation implies what you have implied in your question, that it is a recurrent event. The vast majority of patients whom we enroll into the ARA SCAF anticoagulation studies, and the main ones are Artesia and NOAA, have 1 or 2 of those episodes per year. And they last an hour, maybe 2, maybe 3. And then 3 years later, they may have another day. I do not think that any form of rhythm control can improve that if you think that the time that you spend in an arrhythmia is relevant for the outcome. It's just so difficult to reduce that you will probably do harm. And that is different from clinically detected atrial fibrillation, where the burden of arrhythmia is typically a lot higher by the time that you detect it. So whether atrial high rate episodes or subclinical atrial fibrillation are a normal variant, like, well, I'm tall, I'm at higher risk of atrial fibrillation, but that doesn't mean that I'm undergoing an AF ablation tomorrow. Maybe someone with atrial high rate episodes is at slightly higher risk of stroke, but whether that means that anticoagulation is helpful is really an open question to me. And we'll find out in the next 2 years, I hope, maybe 3, but we'll be able to tell you. And Jeff Healy and his team who run Artesia will be able to tell us. And I think then we'll know. Regarding implementation, well, there is nothing that's more difficult to change than people's behavior, right? So no surprise that implementation is difficult. One would hope that many treatment decisions are taken on a rational, evidence-based basis, but sometimes they're not. And implementation takes time, just as clinical trials do. And you can always argue that it should be quicker. But there is also a reason why doctors are conservative by nature. And not every innovation that looked good at the start was a true innovation in the end. And that, of course, comes back to power. And if you only consider adequately powered evidence in your treatment decisions, you're probably being a lot more rational than the average physician is.
Thank you very much.
Yeah. Javid, I let you wrap up. This is your session.
Thank you very much, Dr. Kirchhof. Thank you very much, Paul. I think I can say that for both of us and for all the audience, we appreciated your insights very much. You know, it was a blast. Thank you very much.
Excellent.
Thank you.
Have a lovely evening. Thank you.
Have a
Bye-bye.
nice evening. Bye.